pericardial disease, pericarditis, all that fun stuff. But first, we will do some check on learning from our previous lecture. All right, you got a 64-year-old male, presents to the ED with chest pain, EKGs obtained with acute chest pain. What is your interpretation of this? What are we thinking here? Looks like a lateral STEMI, right? Yeah, you got ST elevation, especially in those like high lateral leads, and one in AVL. And then you do have ST elevation in your other lateral leads, especially 5 and 6. Maybe you could argue 4, I don't know about that, but maybe. Definitely in a hyperacute T wave would be 4. Yes, so what's our initial treatment? You get this EKG, what is our initial treatment for this? Don't overthink it.
IV O2 aspirin.
Yep.
Nitro.
Yeah, IV O2 aspirin. So make him chew up some aspirin. Good. And then if his blood pressure can support it, what would we do?
Nitro.
Yep, nitroglycerin. Good. And what do they need? Definitive.
PCI.
Yeah, they need PCI. And what's the time frame for that? 90 minutes. Yep. At a PCI facility, 120 if not. Good. Good. All right. I know the EKG is a little small, but based on this one, which coronary artery is most likely occluded? What do we see on here?
Anterior lateral, so lat, LAD.
What is this called? This sign? Yeah, I heard it. Wellens. Yep, so this is a Wellens. Good. So yeah, that would be D, your left anterior descending artery. Go ahead. Let's see if we got another one. All right, 65-year-old male. History of stable angina, hypertension, hyperlipidemia, reports of AD with acute chest pain. EKG reveals ST elevation of 1.5 millimeter in leads, 1 in AVL. Current vital signs are 87 over 55, heart rate 102, respiratory 24, respiratory 295. What is the next step? Next best step in managing this patient? Where did I heard some. All right, so did somebody say D? Yeah. Why not D? Yep, blood pressure's not gonna support it. You're gonna kill him. Good. All right, and then he has STEMI, so B's not, we're not gonna necessarily give you troponins. We already have ST elevation, and one's just wrong. And then same with E. All right. So C is the correct answer here. All right. I don't know why everything's so small on this one. I don't know what I did here. All right, 68-year-old male is brought in by his wife to the ED for severe chest pain, history of hypertension, tobacco, denies any medication allergy, told his wife about 24 hours after its, electrical properties. And we categorize them like a lot of other things, whether it's primary or secondary causes for this. So primary, we have like hereditary and genetic cardiomyopathies. And those ones mostly are related to predominantly involve the myocardium. So we won't discuss a ton of those. Mostly we're focused on the most common cause, which could be that secondary cardiomyopathy from like hypertension is our most common cause. It is, third most common form of cardiac disease. It does lead to significant sequelae like heart failure is one of the concerning sequelae that we see with this. So, it may be familial, but it usually occurs with other cardiac diseases or systemic diseases like disorders like hypertension. We can also see it in like the peripartum period, which is something we always need to consider in anybody that's about to deliver or has just delivered a baby or in the last like 6 weeks or so. I think it's actually to 12 weeks for this one, but that doesn't matter. But it is something we need to consider in like a chest pain, especially in a postpartum patient. And like I kind of said in the last one, our concern is heart failure. So it is a major cause for heart failure, and it can lead to cardiac transplant. And dilated cardiomyopathy is the most common form of cardiomyopathy. We also see it, like when you're, alcoholics, we see this in, we may see it in like chronic cocaine or amphetamine use. And here's some parasternal long images of the heart, and one is what it should look like, and on the left, and then hopefully we can agree the right-sided one is abnormal, or it doesn't look the same, right? So you kind of see that stretching of that left ventricle there. And so we would call that dilated, and that would be a concerning finding on there, or help us diagnose this. And then here's another image of dilated cardiomyopathy. You can see the, I thought it was a video. Is it playing? Yeah, so this one, you got a dilation of the, which vein? Which vein are we looking at there?
Right.
Yeah, the right vein. Good. All right, you guys are experts, man. All right, so dilated cardiomyopathy, usually, this is, we see it a lot in elderly too, but a lot of times we'll see it diagnosed at younger age, typically like 20 to 50. And they can have, usually they present with CHF, so they'll have some sort of shortness of breath, dyspnea on exertion, maybe orthopnea. They might have signs of like volume overload. And on those last images we saw, it's characterized by dilation and impaired contraction of one or both ventricles. So this is like a low cardiac output, signs of CHF. I think we talked about the next slide, how we talk, but it'll come up here. But we talk about whether it's heart failure with reserved ejection fraction versus preserved. And on your like inpatient rotation, you'll see them called like HFpEF versus HFrEF. All right, so it makes sense. Like you have a decreased neck compliance, you get kind of balloons up, and then you get an increase in those capillary pressures, and then you get that dilatation, whether it's the left vent versus the right vent. Usually it starts with left vent and then it can turn into right vent dilatation as well. And then you'll see a normal wall thickness in this, so we're not thinking it might be some other cause, which could be a hereditary, or it could be like what else causes, especially like a thickened septum of the heart, which we'll talk about next or later. Anybody want to guess? Causes syncope. We see in young, healthy athletes who pass out. Yeah, hope. So that's where you see that thickened, septum. Good. All right. So clinical features, like I kind of mentioned earlier, signs of heart failure. So dyspnea on exertion, orthopnea. You may have, the shortness of breath when they're laying down at night. They have to sit in a chair. You might hear signs of like pulmonary edema. And then they may have that like pitting edema in their lower extremity, or other signs of volume overload with this that you would see with heart failure. Did we talk about heart failure, or is that coming up? I can't remember. Did we go over heart failure? I don't think so. I think that's coming up in the next few lectures. So that's where we'll focus more on the treatment. The clinical features, you'll have that dilatation. Other presenting things you might see if it's undiagnosed, they run the risk of getting some sort of thrombus in that like atria, because you have stagnated blood in there, the heart's not pumping appropriately, and you can see signs of like stroke, pulmonary embolisms, and other complications. Like it can throw clots down in the lower extremities, and you get a pulseless lower extremity. You may get like that hematuria flank pain. So really, those thrombi can go anywhere in your vasculature and kind of clog it or occlude it and create other symptoms. So just something we want to consider when we're treating like a stroke patient. What's the cause of the stroke? Which most commonly is going to be AFib, which causes, because your atria aren't contracting, it causes the same thing like this does. You have stagnating blood in there, and it runs the risk of, creating clots or thrombi. All right. So diagnosis. How are we diagnosing these? So, it's hard to definitively. We're diagnosing it with an echocardiogram. So we're looking at the cardiac function. We're looking at the filling pressures. Sometimes you might see things on a chest X-ray, like what are these, the water balloon heart or whatever. You may or may not see it on a chest X-ray. If you don't see it, you can't really rule out a dilated cardiomyopathy, but it is something one of those ancillary tests. It's a little bit faster that we get on everybody that comes in with chest pain or signs of heart failure. All right, so EKG findings, nothing is definitive to say, oh yeah, this is a dilated cardiomyopathy, but you're gonna see signs that, like you would see for, let's say they have, uncontrolled hypertension, you'll start to see those other findings like a left ventricular hypertrophy or left atrial enlargement. Common dysrhythmias might be AFib, you see with this. And once again, EKG is just going to show those, large QRS complexes, depending on the lead. They're very deep. It's over that 35 millimeter if you count the two different leads. But really, what we're looking for in echo is that decreased ejection fraction. So that's what we call, heart failure reduced ejection fraction. We call it FREF. All right, so when do we get an echocardiogram? So really, any patient that doesn't have the diagnosis that we're concerned for, but our initial management is the same like everybody, IV O2 monitor. We need to make sure the patient is stable first. Most commonly, if we suspect this, we want to get an echocardiogram. The question is, are we admitting the patient for this? So if there are signs of, like instability, if they have, heart failure, hypoxia, they're not able to move that blood appropriately, and you got those significant findings of edema. Those are patients we're likely going to admit and get an echocardiogram when they're inpatient. If the patient's, asymptomatic, mild symptoms, we might send them for an outpatient echocardiogram. I would still call the internist or the cardiologist and be like, yo, I want to admit them, and they would tell me to do it outpatient. So, all right, I think those are the same images we had in the first ones. So you guys kind of already saw those for that parasternal long view. All right, here's another one. Does that look normal? Well, that was like not normal, right? That's a really dilated left ventricle there, so. All right, so what do we do for them? So we're gonna treat the signs of heart failure, which we'll discuss, I think it's tomorrow's lecture. But really, we're looking at certain treatments that are gonna help acutely, which, we wanna reduce usually that blood pressure work of the heart. So a lot of times we're gonna give nitroglycerin, we might give Lasix to help them diurese some of that excess fluid off. But we'll cover that tomorrow. Some of the chronic management it says on there, that's not something we normally start in the emergency department for them. And then they'll, eventually be managed by cardiology, and they can look at cardiac resynchronization. Sometimes they'll put an implantable cardioverter or defibrillator in there, especially, patients that are at risk for sudden cardiac death, which some of the, concerning things we look for are like family histories of sudden cardiac death. If they are having like syncopal type episodes, we may consider an implantable or an ICD. So a lot of times if they know, if it's known or they have a diagnosis, they'll present with like worsening chronic CHF type symptoms, which is going to be shortness of breath, maybe chest pain, maybe signs of volume overload, and then we treat them with nitrates, diuretics. It depends on what their blood pressure is looking like when they come in, on whether we give nitrates or not, which we'll cover extensively in the next lecture of when we give it, depending on the type of heart failure. And then we want to make sure they get a follow-up. So most of the disposition for these, they present to the ER because they're having these symptoms. So a lot of times we're going to admit them unless it's very mild. They have a known history. We have an echocardiogram on file for them. They're being treated. And really a lot of times when that happens, they ran out of their heart failure medications or their blood pressure medications and have precipitated this. Or there's some sort of other, infection that might have precipitated it. So those patients we might consider, outpatient management. Most of them are going to be coming into the hospital. But we also want to, ensure we rule out all the other causes. So chest pain, we treat them all the same. Everybody gets IV, O2 monitor, aspirin. And then we get EKG, chest X-ray, troponins. We want to rule out ACS, especially in these patients. And then when we want to consider other causes, like we'll talk about in the next lecture for aortic dissection. All right, here's some other treatment. So like end stage in this, they might be hospitalized and they put what we call an LVAD in there, left ventricular assist device, which is an interesting looking device. So they implant it in there and it basically bypasses their left vent, or it not bypass, it assists their left vent, the left vent's function, and they wear this like purse looking thing with a battery pack on it and a machine. So these are interesting patients, not very common, but you will see it if they're pending like a heart transplant. And they come in and like when you listen to the heart sounds, you don't hear a heartbeat, you just hear, it's like a machine running in there. And we won't get into like the more advanced things, like doing CPR on them. It's not appropriate, you know, there's a lot of different management for that we won't get into, but they're interesting. Next one we'll talk about, this one is something, you know, that you guys will encounter like in an outpatient clinic, because you know, an EKG or an echocardiogram isn't required to join the military. So everything we're doing is based on physical exams. So sometimes these patients may end up, you know, at your clinic because they had like a syncopal event, or they're getting real short of breath during while they're PTing, and then you may diagnose hypertrophic cardiomyopathy. So it says it's the second most common cause of sudden cardiac death in adolescents. I think it's the leading cause of it right now, but it doesn't matter, we won't get into that. We usually don't make the diagnosis in the emergency department because EKGs aren't diagnostic for hypertrophic cardiomyopathy. This is something that your physical exam can be very helpful, and an EKG with it showing that left ventricular hypertrophy. You might have those dagger-like Q waves, which are classic findings, but it's not guaranteed in these patients. So this is like suspicion from your physical exam and the murmur, which we'll talk about. But this is a deadly arrhythmia if it happens, and that's why we want to catch these when we can. So you'll have, you know, unexplained left ventricular hypertrophy. You get the non-dilated ventricles, but you get that really thickened septum is what we see in these patients. And it's usually like an inherited or genetic condition, so it's autosomal dominant inheritance. 1 in 500 is not super common. I was trying to look at what else is 1 in 500 that's common, and not a lot. Like it said, like Klinefelter's 1 in 500. So I guess it's not super common, but not, 1 in 500 is like the mark between common and rare. So it's, you know, one of those in between that you may see it, you may not. It does have a, you know, less than 1% mortality rate per year, but especially in the younger patients, it is a very common cause of mortality. All right, so you get that hypertrophy in that left ventricle, and then you get decreased compliance because you got that thickened septum, and so it's not able to fill appropriately, and then when it contracts, it's not able to move that blood into the circulation like it should, and exercise is kind of what precipitates this, or strenuous exercise. Yep, so they may present with palpitations, they may present with shortness of breath, you know, during exertion. Don't see a ton of AFib with it. If we do, it's usually a very poor sign. And then a lot of the other findings we're not gonna see on there. You may get a pre-systolic lift, which I don't know that I've ever noticed that on physical exam, but maybe I should, I don't know. And then you might get, you know, that apical impulse. Also what we're looking for is like that specific murmur on these patients. Here are the clinical features, like I said earlier, dyspnea on exertion. So anything that increases their heart rate is gonna cause elevated left vent diastolic pressure, and it's gonna be create and become symptomatic. So they might have chest pains, syncope is a very poor sign, palpitations. And these are patients we want to ask because it's inherited, like, do you have any family history of sudden cardiac death? Which in the ER, there are like few questions we ask for history. These are one of them. All right, So you get that chest pain because you're not able to move that blood through the circulation appropriately because you have that, hypertrophy kind of blocking the outflow tract of the left vent, and it can create symptoms in these patients. If they've survived, if they haven't been diagnosed and they show up later in life, they might already have coronary artery disease, and that also limits the perfusion and makes it worse. So, most of these are diagnosed younger. They might have just precordial chest pain. They mimic angina. And then these are patients we don't want to give any sort of nitroglycerin for. All right, so here's our heart sounds and things you might hear with this. So you usually have a normal S1 and S2. You may hear an S4 in these patients. The big ones are going to be that murmur that we hear when it should decrease the murmur sound, and hopefully it makes sense in a second. So anything that decreases that left vent filling pressure is going to accentuate that murmur. So if you think about it, you have that thickened septum, and it's blocking that outflow tract. So if you're not getting enough blood in that left ventricle, you're not gonna, for all those maneuvers that we do that decrease the filling pressure preload, the heart's gonna not have enough blood to dilate that ventricle when it squeezes, and so that thickened septum blocks the outflow tract. When the left vent is filled and expanded appropriately, you usually don't hear that murmur, which is the opposite of what we've learned for all the other murmurs and when they should increase versus decrease. Hopefully that makes sense, but anything that decreases that filling pressure, like squatting, passive leg extension, hand grip, is going to decrease the murmur. So when they go squatting to standing, it increases, which is opposite. And here's a little chart, kind of explains this. When you Valsalva straining, standing after squatting, increases the murmur, and then everything else is going to decrease it, which is opposite from all your other murmurs that we are concerned for. I've diagnosed plenty of hokum. I didn't hear a murmur though, but maybe I just have bad ears, I don't know. I have been using the same stethoscope for 10 years. Because like when, it's like a sports player, like when it's working, you're like, man, I can't cut my hair, I can't do this because I'm, I got a lucky streak, so I'm like, well, it's been working out, I don't want to get a new one. Somebody's probably gonna use it one day, and be like, you can't hear anything out of this. Some of those newer stethoscopes are actually, really great for it. They're electronic now, and it amplifies everything. So it just depends on what you want to use. Mine I stole from an MES set in the Army, and been using it for over a decade. All right, so once again, there's not any specific findings on like our EKGs, chest x-ray, physical exam. We want to look for that murmur, but really definitive testing is going to be confirmed with an echocardiogram. Like I said, EKG is just going to show that left ventricular hypertrophy and those like dagger Q waves, as we call them, for board questions. So it's something to look for, especially, this is a common board question, especially in the STEM, when you're reading, a syncope or a chest pain or palpitation patient, they're super young. Something I would consider when I'm reading that STEM. Like, okay, what could be causing this? Are they talking about like a recent viral infection, which we're talking about next? Is this like a pericarditis, or could this be, hypertrophic cardiomyopathy? And then you'll see that septal hypertrophy on the echocardiogram. Here's our classic EKG findings. So you have that left ventricular hypertrophy on there, so those deep S waves. And then you have those Q waves in your septal and lateral leads. And that would be like a classic finding for hypertrophic cardiomyopathy. Common like board EKG too, you're gonna wanna look for those Q waves. Like I said, it's that younger patient, they probably shouldn't have had a prior MI, right? Q waves on there, so something you wanna consider. And then here's what that left ventricle looks like. So I think we can agree the one on the left is not normal. It's very thickened and hypertrophied. So we have a normal parasternal. You guys know what view this is?
Subxiphoid.
No.
Just like
It'd be like a parasternal short, but we actually probably, it's not even probably that. This would be a specific one, but that's what it's closest to. So a lot of times when you're doing that which you'll learn in ultrasound, but when we cover it, the parasternal long gives you that great view of the ventricles and the atria, and you can see you can see most prominently like that mitral valve kind of opening and closing. And then we turn our probe a little bit and we get a short axis view looking through the heart a different way. That's what we see this. All right. What do we see on here? Which one's normal? The one on the left, right? So that one on the right, it's almost like, man, what am I looking at on there? Wow. So you see how thick that septum is? Where you can see the mitral valve open on there, and then you got that extremely, like, that's not normal there. So it should look similar to this. You see how large it is. So it causes, significant symptoms in the patient, especially with exercise when it's that bad. All right. So once again, common cause is going to be chest pain, exercise intolerance. What is extremely concerning is a syncopal patient with this. So that's kind of a very concerning finding, especially in when they present to the ED, because they have a very high risk of sudden cardiac death. So usually that's like that sports player or somebody out at PT and they syncopize. This is something we need to make sure we're ruling out. All of these patients that we diagnose in the ER, we're going to admit those patients for an echocardiogram and a cardiology referral, because all of them are going to be started on treatment which is usually a beta blocker, but some of them are going to need to get that implantable defibrillator, especially if they've had a syncopal event. Have you guys seen those videos like of the dude who's playing soccer and just he passes out, hits the ground, and all of a sudden you see him go, and then he like gets up. He had an implantable defibrillator. It's like, holy cow, I would not play sports after that. But I guess if you're that good, whatever.
Yeah, I really love it.
All right.
You got paid for the defibrillator.
Yeah, he's got the defibrillator. Hope it works every time. So if it's suspected, in a patient with syncope, we're admitting them. If it's suspected, if they're not, if it wasn't a syncopal event, we're still going to admit them for an echocardiogram. And we're going to consult cardiology, and then they're going to decide whether it's something they want to manage outpatient, which they likely will. And they'll counsel them really well, like no sports. You're going to be started on beta blockers, and it's kind of tailored upon the patient. But most of them are not going to be playing sports anymore unless they don't listen, and then they syncopize and go into cardiac arrest on the soccer field and get shot. So how do we diagnose this? It's not a trick question. Echocardiogram, good. What do we use for treatment? Good. All right. And then here's some other cardiomyopathies that you might see, especially with those like primary causes. You can have some sort of like infiltrative disease. We won't get into the restrictive cardiomyopathies. And really, most of them all present in a similar fashion. Congestive heart failure type symptoms. Usually they show up because they have like an acute decompensated heart failure picture, and we diagnose them with restrictive cardiomyopathy. We also have Takotsubo, which is a stress-induced cardiomyopathy, like broken heart syndrome. We see this commonly on board questions too. And like if it's an elderly patient and they randomly mention somewhere in the stem, like their husband recently died and they're presented with chest pain, think about this one. So this one presents exactly like a STEMI. We do the exact same management for it because we can't differentiate. So they'll have ST elevation on their EKG, and then when they go in and cath them, they have clean arteries. So this one can be fatal. I don't know. I've never seen a Japanese octopus trap, but apparently that's what it looks like. So you have bulging in the left ventricle, and apparently it resembles an octopus trap. I don't know, but we treat these the same. So we we want to treat them just like a normal acute coronary syndrome or a STEMI. They go to the cath lab and they find clean vessels on there, and so then they end up getting diagnosed with. They get an echo and they diagnose it after the cath lab, because we treat it as a STEMI, so they're going to get the cath first, and then they'll look at possibly doing an echocardiogram afterwards. So here's our like classic EKG. Looks like a STEMI, right? Yep. Looks like a STEMI. We got reciprocal changes. We got elevation in that in those anterolateral leads. So we would we would call a code STEMI on this, do the same treatment we do for everybody. They go to the cath lab, but it's something to consider. I never diagnosed one. Maybe someday. All right, moving into more common things that we see is going to be our pericardial disease. So this is like pericarditis, and then what we're worried about are some of the complications associated with this, like an effusion or worst case cardiac tamponade. But this is really just we have that sac that surrounds the heart, and it has like a small amount of fluid in there, and really cause anything that causes inflammation can cause this. So we'll talk about most commonly what they present with, but really we get an excess amount of fluid in there is what we're worried about. Most of these patients just present with chest pain, and because of the inflammation is in the heart, we run the risk of getting fluid in there because it's proximity, so since it surrounds it. Hope that makes sense. All right. So most common cause, we don't know. So a lot of patients, we don't find a cause for this, or most commonly the causes that we do find are going to be some sort of recent viral infection, like an upper respiratory infection. Coxsackie virus is commonly implicated with this one. You can also see it with many other causes. So malignancy is another one we see it with. Autoimmune, trauma, uremia. I've never seen a fungal one. I think I've seen all the other ones on there for it. I feel like that'd be horrible, having a fungal infection in your pericardium of the heart. All right. So what do they present with? Some sort of sharp stabbing chest pain. It can present, gradually. It can present suddenly. It may radiate to the back, the neck, shoulder. Worse with inspiration. So this is like when you get that pleuritic chest pain. We can get due to the inflammation there and the diaphragm, you get left trap pain on the ridge with these patients, are another distinguishing feature. But once again, we treat them all the same. They come in with chest pain, we want to get EKG. We usually give these patients aspirin still as well. Usually we don't give them nitroglycerin, so some of it is based on your gestalt and your physical exam, and you may have them if they are supine, or they may present, say it's worse when I was laying down. It's a little bit better when I sit forward. Especially on like test questions, they like to say that to help you differentiate all the other causes of chest pain. Because at the end of the day, really, we learn all this, but everything presents the same. So that's why we cast kind of a broad net for a lot of these. On a board question, the only way to differentiate is by using the words here, but in real life, everybody presents differently, so they might have pain somewhere else. So it's like one of those things. We won't get into the real life picture, but it can be difficult, so that's why we have to suspect this. This pericarditis is more of like a diagnosis of exclusion for us, so we want to rule out acute coronary syndrome first, and other causes of chest pain like EE, things like that. You might hear that pericardial friction rub on it. I've diagnosed a lot of pericarditis. I don't know how many friction rubs I've heard. Once again, I probably need a new stethoscope. But it's best over the diaphragm at the left lower sternal border. And it's more prominent when they're sitting up and leaning forward. Other things to consider when they present, like always want to consider that recent upper respiratory infection. And then they may or may not have a fever with it if they're still if there's a lot of symptoms from the infection, so that can help you out as well. All right. So once again, with EKG, chest X-ray, we want to get a troponin. Other than NSTEMI, why do we want to get a troponin in these patients?
Make sure it's not an MI.
Like a myocarditis is what we're concerned for with this. So And one of the ways we kind of differentiate whether it's pericarditis versus myocarditis is going to be that elevated troponin. You don't see ST, well, you will see ST elevation, but it's usually like a gross ST elevation. And then the troponin can kind of help guide you with whether you're thinking it's a myocarditis. All right, so here's what we see on the EKG. So usually you see that gross ST elevation and PR depression, and it kind of goes in stages depending on the EKG findings and how what the time frame is. Usually in the first week to 2 weeks, they'll present with that characteristic stage 1 acute findings of chest pain. You'll have that ST elevation and depression, and we'll show some images here. And then when you get into stage 2 and everything else, it really could look normal. Everything's returning back to baseline, and it'll make sense on these EKGs. But usually the stage 2 is like 1 to 3 weeks. Stage 3 is 3+ weeks before it might normalize. So here's a picture of stage 1 pericarditis. So can everybody see that like ST elevation? It's in quite a few of the leads. One of the measurements we look at is like whether V6 is the T-wave amplitude V6 compared to ST segment, and whether it's 0.5 or more, 0.5 or less meeting criteria. But really what we're looking at is that gross ST elevation, and then we have PR depression. So in some of those leads, you can kind of see it doesn't look like a ST elevation. Maybe you could argue too, but I don't think so. But really, it's not elevation, it's PR depression. So you're looking at the PR depressed, and it's not at that isoelectric line. So it's likely not, that one's likely not an ST elevation, but you can see significantly the other leads, like moving into your anterior and lateral leads, that kind of gross elevation in there. And then stage 2, so the ST segments are starting to normalize a little bit. They're slowly returning to that baseline. And then stage 3, it all looks relatively normal except for some T-wave inversion in, especially your lateral leads. And you see some T-wave inversion in inferior leads, and then after this is when it normalizes back to baseline. What we're worried about is a myocarditis or a pericardial effusion in these patients, so that can, affect the function of the heart, because we get that fluid filled in the pericardium, and it, reduces that contractility of the heart. It's not able to pump appropriately, and so that's, something we want to consider in all these patients, especially if there's any signs of like instability. They're presenting hypertensive, tachycardic. We need to consider this, especially if we see some EKG findings. Chest X-ray is not super helpful on this, but we get them on everybody. What we need to do is look at an echocardiogram if we're worried about any sort of pericardial effusion or fluid around there. So we can do that at the bedside, or we can put them in for a formal one. Normally we do it at the bedside and kind of determine whether we think there's an effusion or not. And then here's some pictures. So this one's pretty minor. So you got, does it look normal on the left? Abnormal, what do we think? Yeah, it looks like a normal one, right? That's going to be your subxiphoid, or subxiphoid view there, subcostal, whatever you want to call it. Then we have a subxiphoid view here with an effusion, and you got a positive arrow sign on there. But most prominently, or where you see it start, is in between where you would normally see the right ventricle and the liver, where you're going to first see the fluid, and then you can see it start surrounding pericardium. All right, so most are idiopathic, or we presume they're viral. A lot of times they'll have had a recent, like URI last week is a very common presentation. They'll say, oh yeah, I was sick last week, I had a cough, congestion, runny nose. And then they presented acutely with this chest pain. Most of them benign course, so we just treat it normally with anti-inflammatories. So Motrin is a great one, or ibuprofen, just because it has lower cardiac side effects. And then we also want to look at colchicine as well. So this is beneficial, and one of the things, we like about adding colchicine is it prevents recurrent episodes of the pericarditis. So we'll usually add 0.5 milligrams of colchicine for our treatment for these patients. Unless they have an elevated troponin or an effusion, then we're usually gonna discharge all of these patients home. And then we'll have them follow up with their PCM, and they might get an echocardiogram. Some of the, concerning findings are gonna be on this next slide. So if they have any of these, this is more concerning like a myocarditis. So fever, it might be like a subacute onset, so it's been going on for a couple weeks. Anybody that's immunosuppressed, so that if they're like on chronic steroids, if they're, HIV, diabetics, things like that, we may want to consider it in. Anybody who's taking an anticoagulant or an oral anticoagulant, we want to consider, a myocarditis. And then any heart failure symptoms or large effusion, but really what, most of the time is what our concern is like any elevated troponin in these patients, especially if everything else is normal and their vital signs are stable. If they're like hypotensive, and febrile, we're gonna admit these patients and consider it like a myocarditis, especially if that tropes up. All right, so this is kind of our biggest concern, and that's gonna be that cardiac tamponade. So really you get a significant amount of fluid in that pericardium. It limits the function of the heart. So you're taking away some of those squeeze properties because you're filling it with fluid, so it's not able to expand like it normally does when it's filling. And then it leads to that cardiac tamponade type symptoms. And what are those symptoms? What's that triad? Yeah, Beck's triad, right? Yep. Hypotension, JVD, muffled heart sounds. And then we want to get an echocardiogram in all these patients. But here's kind of what I just said, the ventricular filling's restricted, and it's not able, to pump appropriately because of that or fill appropriately, so you're gonna present with those signs of hypotension. And we confirm it with our echocardiogram. So here's an echocardiogram. You can see a significant amount of fluid. Not super impressive, but every patient's different. If they present with those tamponade type symptoms, and we're gonna call it a tamponade on that. I think if we're, atraumatic wise, the most common reasons I've seen this are gonna be malignancy. So I've seen this a lot in those like cancer patients, or anybody with a malignancy is what we see it the most in. And then next we'll see it with like pericarditis. That's why we want to consider all those concerning findings that we had on a couple of slides ago. We want to consider that, is this an effusion or a tamponade associated with this? And then other causes like, hemorrhage, like taking anticoagulants. Hopefully that makes sense. Maybe tuberculosis. Not in this country, but other countries it's probably pretty common. All right. Symptoms are non-specific, just like everything else. So maybe some dyspnea at rest, or with exertion they present with that. They may have some chest pain, or maybe they previously had a pleuritic chest pain or pericarditis type symptoms. And then we consider other diseases like any, uremia. Do they have kidney failure? Could this be a tuberculosis patient? And then physical exam, you may have that, the JVD, hypotension, muffled heart sounds, tachycardia. You may have a narrow pulse pressure, pulsus paradoxus, supposing you check that. So you have to get a manual blood pressure with that. And you have a blood pressure variation during inspiration and expiration over 10, and that's how you can diagnose that. Like I said, those distant heart sounds, muffled heart sounds, another thing we call it. Normally you don't have those other findings of like congestion or heart failure with these. And then chest x-ray can be helpful. You may or may not see it. It's not definitive on chest x-ray. EKG, they may or may not have the electrical alternans. It's classic, but it's not very common on our EKG findings. But it is common on like multi-questions. So there's what you may see. There's a normal on the right. You got that large like water balloon type looking heart on there for a large pericardial effusion. And then there's, another image where you kind of see that fluid surrounding the heart, or that outline around the heart or pericardium. And then here's our x-ray. So what do we see on here? Everybody remember electrical alternans, kind of understand that you have different wave amplitudes on this EKG. So, with between each beat, you're getting that electrical activity is kind of reduced. So you see a normal QRS followed by an abnormal one or a low impulse one. Good. So this one is something we need to suspect on physical exam or on their history when they present and their vital signs. So we have that hypotension, you might have muffled heart sounds, JVD. We can, the diagnostic test choice is going to be an echocardiogram for these patients. And then you may see large, fluid volume there. You might see right vent collapse. There are, other findings on there that you guys don't really need to know, but those are going to be like your main ones. Fluid surrounding that heart, and you're going to kind of see that impaired function. Here's a good one. So that's like you guys see how much fluid is surrounding the heart on this one, especially like at the top of that image. You got a pretty significant amount of fluid on there. And then here's another one. So this one, it's impaired. It does have impaired filling. It's not as impressive as the last one, but you can still see the fluid surrounding the pericardium there. Here is a very severe one. So there's a lot of fluid in there. So what do we do for these patients? We want to start with the fluid bolus. So we want to improve that hypotension so that it can help increase that cardiac output. It's only temporary though. So that's going to be our initial management in the emergency department. We want to get them fluids. We want to get a echocardiogram or a point of care echo so we can evaluate for any fluid surrounding that heart. And then definitive therapy is really, I don't know if I call pericardiocentesis definitive. Really, they need to go to the operating room for definitive treatment. We can do an emergency pericardiocentesis in the ER, but that's going to be only a temporizing measure until they get definitive therapy in the operating room. And they can do, and I think she covers it during the next block for surgery, but they can do like pericardial windows and other procedures to help fix this. And here's an image, pericardiocentesis. We basically use a very long needle, it's like this big, and we go subxiphoid all the way till we hit the pericardium, and then we drain that fluid off there. We use ultrasound a lot more nowadays, but the original way was just like if you were doing an IV, or if you're aspirating fluid, you had a giant 60 cc syringe and you were pulling traction and aspirating it, you were advancing until you got blood. So it's pretty scary procedure. I think I've only ever assisted in one because we try to get them to surgery because it's not the best. Scary for us in the ER. It's not something we like to do. But they can put like a pigtail catheter in for drainage. They can do a pericardial window. Some of these patients will get a complete sternotomy or thoracotomy to diagnose it, which is not good. I had one, this is a trauma patient in Iraq, and it went, he got a shrapnel wound that kind of went in the side and nicked the pericardium, and he ended up coding, and we opened his chest up, and you see his heart beating. We're like, okay, what's going on here? There's a little nick on there with some blood, and the surgeon's like, give me a Foley catheter. And I'm like, dude, Foley catheter, which is for urine, right? That's what you place. That's what you place when they're under anesthesia or in the operating room, so that you don't get pee all over you. They don't pee everywhere. So he actually stuck the Foley into this little nick that was on there, like blew up the balloon and just started pulling fluid off. I was like, holy cow, that's pretty smart. And then we went right to the operating room while he held it. It was interesting. Interesting case. Not very common to see that, but that was pretty quick thinking on his part. I was confused, that's for sure. And then here's another image. You can see that fluid there. Or this image of pericarditis. So you guys see that little, like, on the right side, you saw the needle come in and out. This is why it can be hard, and you guys will find out when you're doing IVs with the ultrasound. It's kind of hard to find your needle sometimes because you're looking at that beam, just shooting one little beam down like a slice, and you're trying to find where that needle is and the metal in there. So that's why it's pretty scary. It can be difficult to find where your needle is. Which the ones I've seen or assisted in, they didn't even use ultrasound. They still did the old school way. All right, so here are some take-home points. So we're looking at dilated cardiomyopathy. Most common cause is going to be your hypertension. So that's something to consider for your your dilated cardiomyopathy. You also see like alcoholics commonly with it as well. So those are considerations with the patient's history that you want to think about, especially with cardiomyopathy. HOCM, genetic thickened septum, you need to remember those murmurs and when they increase versus decrease. Normally they present with a syncopal type episode for those. Yeah, restrictive cardiomyopathy, whatever. We don't really talk about it much. And then Takotsubo, so that STEMI or STEMI presentation. And they have clean arteries on their cath. Really what we see a lot of times on like questions, it's gonna be, like I said, some elderly patient whose husband recently died. And they have EKG findings, a STEMI on there, so we need to consider Takotsubo. All right, what questions y'all got? I feel like you never have questions. I like you guys. All right, take a 10-minute break. Be back because most patients die, usually before they get to the hospital, if they made it to you. It can be pretty scary. So here's our reference. I don't even know why I have it on there. I should probably delete it. It was always on there, so I left it on later. All right, so we'll do the same thing. We'll talk about aortic dissection, epidemiology, pathology, diagnosis, treatment, and everything else associated with it. We'll also talk about some hypertensive urgency and emergency. We don't consider hypertensive urgency anymore a thing, but we'll talk about that. Here's our warm-up case. So, 75-year-old male, presents the ED, he's got that sudden onset, severe ripping, chest pain, radiates to the upper back. Vital signs are blood pressure 197 over 99, heart rate 92, temp 98.6, respiratory 24. So, we'll get into what we're going to do for this, but this, same thing we do for everybody, our safety net, IVO2 monitor. And then this patient, gets managed a little bit differently during our acute period. We suspect that it's a dissection just because of the high mortality rate associated with it. We have to move fast for these patients, a little bit different treatment. So here's kind of what I just said. IVO2 monitor, if we suspect a dissection, this is where normally we're getting, our EKG, our chest x-rays, we're drawing our labs. If we're concerned for dissection or have any suspicion, this is a patient we want to, obviously ensure they're stable, but we want to get them immediately to the CT scanner for a CT angiogram. And then we want to lower their BP and their heart rate, which we'll talk about how we do that in the upcoming slides. But this is like an urgent surgical consultation. These patients need to get this fixed like stat. All right, so we have different aortic syndromes or aortic emergencies. The one we're going to talk about today is going to be dissection, but you can also have things that are similar to a dissection, like you can have an ulcer through penetrating, atherosclerotic, I can't talk, ulcer, that can create a similar presentation to aortic dissection. You can have a hematoma or an intramural hematoma. You can also have like an aneurysm, which is going to be different than a dissection. So this can also rupture and cause leakage, which are all very concerning and something we need to consider in our deadly differentials when we're evaluating these patients. But It's uncommon, but it's very high mortality rate. Even the 10-year mortality rate's like super high, 57%. I wanna say it's even higher than that now. But we'll get into it. So usually this occurs because of some sort of chronic, hypertension. And this leads to weakening of that medial layer of the aorta or the aortic wall. And then you have blood that gets in there and kind of dissects in between the normal lumen of the aorta, and it creates like a false lumen in there. We see it associated with like Marfan syndrome or other connective tissue disorders, bicuspid aortic valves. Also, family history dissections are another thing we want to consider as well, because it can be seen in families. You can see it with anything that increases a lot of those like catecholamines and blood pressure and some of those shear forces, like amphetamines, cocaine. It increases their risk of atherosclerosis and dissection. Prior cardiac surgery is another risk factor. And then pregnancy increases the risk as well. Still very uncommon, but it's something we need to consider. It does increase it, like four times the risk for it. All right. So really, the two common places we get concerned for are gonna be like, mostly we're talking about thoracic region in this lecture, but we also can see it in the abdominal region with the abdominal aorta as well. Most of these are gonna, if we remember our Stanford types, which we'll show some pictures, most of them are Stanford A, which is gonna be like the ascending aorta after it leaves the heart. And they're gonna need like cardiothoracic surgery immediately for all of these. But here's some of our pathophys. So you get some sort of violation of that intima wall. So if we remember, we have three layers: our intima, our media, and our adventitia. And we get some sort of tear or weakening of that intimal layer, and we get blood into the media or the middle layer, and then it creates a false lumen in there and it dissects. Men more common than women, blacks more common than whites, more common than Asians, and then usually it's at the ascending aorta or just beyond the left subclavian. All right. So bimodal age distribution, so usually more commonly in the elderly or older patients with hypertension, ischemic heart disease, but we also can see it in young folks with connective tissue disorders. Like I think I told you guys I had one, or maybe I didn't. I had one in my unit. He was like a 36-year-old and had chest pain and like coded, and they called EMS, and it turned out to be an aortic dissection, and he had Marfan syndrome. He didn't look like your typical Marfan picture though. All right, here's our classification. So really, type A involves the ascending aorta, B involves descending aorta. Because this is medicine, we can't use one classification criteria when we can use two or more, is how I like to look at it. No, you guys don't need to know the different classifications, but it is something I would always kind of remember in your mind. The easy one's Stanford, so is it the ascending aorta, which is most common, so a good guess is always just type A. But we also have our DeMakey classification, which is a little bit more specific in that it's exactly where, so the ascending aorta plus the arch, and the descending for type 1, and then type 2, only the ascending, type 3, only the descending. And here's some pictures, which hopefully make it easier. So here's our like Stanford DeMakey. Can be a little bit more complicated. This one, the Stanford, we would say type A and B, which is nice. There's just two classifications. And then DeMakey's, type 1, 2, and 3, depending on what it involves. All right. So depending on where that dissection is, I think we all agree, sorry, I should have started with this. We do pronounce it dissection, right? I have to bring this up because for like 30 years, Dr. Castro was a surgeon and she taught here. She's like legendary. She'll still come to lab. She's a lot of fun. She spent like 15 minutes explaining how to pronounce dissection versus words that are dissection. So it has two S's, so we pronounce it dissection. Got to bring it up because spent all that time, and that's like one of the only things I remember from her surgery classes. No, she was phenomenal. I mean, she's been here forever. Like, I think Dr. Friccione had her. I didn't know Dr. Friccione was that old, but she said in 1992 when she went through K school, I was like, holy cow, I didn't know you're that old. So she taught here for a long time. She's like in her 80s. She still comes to the lab, still sharp. She's a lot of fun. You guys will love her. She even has her own like Facebook fan page for iPad. So if y'all want to look her up, she's great. We had a life-size cardboard cutout over in our classroom. Like she was just here forever. She was phenomenal. At the last lab we did, she brings old school X-rays, like plain films that are printed. It's a trauma lab, so it's all like chest tubes, complications, intubations. And then she randomly has an X-ray that she throws in there at the end, and she's like, what is this? And it's a penile fracture X-ray. I'm like, she's great. She's a lot of, very knowledgeable. So if she's in charge of any of your labs or your tables, you get all the information you can from her. All right. So the symptoms are going to depend where that dissection is located. So usually, it's going to be some sort of chest pain, ripping, tearing, unless it's, more of the descending, so you might have, some different symptoms. But typically they describe a tearing, ripping pain, and it's sudden onset, severe. These patients are usually going to be very anxious. When you're, once you're in phase 2, hopefully you'll start noticing that once you've treated, enough patients, when they say like impending doom, like some patients look like they're going to die, and these are one of those patients that you look at and you're like, oh man, this patient's about to die, we need to do something. What could this be? We need to consider aortic dissection for those patients. All right. Yeah, so there's some of the breakdown, like 60% had anterior chest pain. So sometimes there can be really minor presentations of this, which are the ones I've diagnosed. And they might show up with chest pain, like significant hypertension. So it is always something we need to consider in our chest pain patients. Depending on where the location is, you may have neurologic symptoms with it. So if the patient has this, presenting with chest pain and they also have stroke-like symptoms, this is something we need to consider. They may have a dissection involving some of those arteries that supply the brain, and they're getting decreased flow there or interruption of flow. Could also cause paraplegia. Like I said, it's like one of the scariest things that we deal with in the emergency department and always worry about and consider. If it's more distal, they may have back, flank pain, abdominal pain, especially if it's that abdominal aorta. They may present with that. And then, you can get a tamponade from it when it's at that cardiac root. Once again, associated with, we want to ask the patient during history, like any cocaine, illicit drug use, are they pregnant or recently pregnant? Any recent procedures, do you know? I don't ask them if they have a bicuspid aortic valve, but I would hope they would tell me, which they probably won't, but I'd hope they'd tell me if they did. And then, is this trauma, and how do they have a history of hypertension? So, family history, once again, like family history AAA is gonna increase that risk. I always ask for these, new patients, especially if they're the right age, do they have family history of AAA or sudden cardiac death, or like the two important family histories I ask in the ED. All right, so our differential is going to be everything that can cause chest pain. So is this acute coronary syndrome? We want to make sure we're evaluating for that. Is this, do they have any pericardial disease or pericarditis? If they have stroke-like symptoms and chest pain is something we need to consider. And then other things that can cause a ripping, tearing pain in the chest is going to be musculoskeletal. And then other trauma-related, like spinal cord injuries, disorders we even need to consider. All right, so exam, what do we see on physical exam? We can see everything or we can see nothing. Like everything else in medicine, we might see it. What we associate with it is gonna be hypertension. So usually they'll have some sort of significant hypertension, like, maybe in the 180s to 200 systolics. If they're hypotensive, that means it's probably gone very bad and they're not gonna make it, it worsens prognosis. You may hear like a diastolic murmur on these patients. And then a pulse deficit is something we want to evaluate on the physical exam, which can be difficult with palpation, but I've definitely thought I've felt a pulse difference many times. But we want to check a pulse deficit between the radials, and then we want to check, carotid, brachial, femoral, DPPT. Neuro exam, if they're presented with any neurologic sequela, so we want to do a quick neurological exam and evaluate whether this is dissecting into those, that vasculature that's going to supply the brain. And it could be quadriplegic or paraplegic, depending on where it is. All right. So your history and your physical can help suggest. We want to always consider it in those chest pain patients, especially if it's like the ripping, tearing, significant hypertension. But our physical exam and chest X-ray are not diagnostic for it. It just suggests the diagnosis. We might see a chest X-ray with a widened mediastinum. And we do misdiagnose these patients, especially if they're not in extreme pain or extremis, or they have normal vital signs. Like they walked in, I think the last one I had, they were a walk-in patient, and I want to say I felt the pulse difference. I was like, oh man, I think that might be a dissection. Let me rule this out. But there's nothing really that's like a slam dunk for your physical exam. Really diagnosis, we need that CT angiogram. And EKG is going to be non-diagnostic, so really we might see just some like ST depression, or really non-specific ST and T-wave change, which we see in just about everybody, especially if they're the right age. EKG can be normal. Like I said, some might not present with chest pain, so it's something we need to always have in our differential. So we don't have a biomarker that is specific or sensitive for diagnosing it. Once again, we need the CT angiogram. But they've studied D-dimer. It's not very specific for it. Troponins not going to be sensitive or specific for diagnosing a dissection. But these are usually labs we draw with any chest pain patient. One thing we like to add for these are like a type and screen or type and cross, because we may be giving blood to these patients, depending on how significant it is. All right, so EKG, chest X-ray findings, the most specific for this is going to be that widened mediastinum. But once again, if it's normal, it doesn't exclude the dissection, so that's what makes it difficult. You may see a pleural effusion depending on where that dissection is. You can have a calcium sign or deviation of the trachea. So here's what a normal chest X-ray should look like, and that just kind of shows some of the prominent findings of the aorta that you would see on a normal chest X-ray. And then we have our widened mediastinum, which this is extremely evident on this chest X-ray. So sometimes it's not this prominent, or this prominent is the calcium sign, so you get a calcified outline of the aorta. All right, so CT angiogram of the chest is what the test of choice is. So this is going to be our most reliable test for diagnosis. And CT angio is a contrasted CT, and we time that contrast, or we time the imaging where the contrast is going to be in the aorta to give us the most reliable findings for this. And what we normally see is like a false lumen, a dissection. We sometimes might see a flap, but we'll look at some images here to help. Yeah, and even with elevated creatinine, like what's going to kill them first? Is it going to be the kidney failure or a dissection? So we'll still CT these patients if we have a concern for it. All right, what are we looking at here?
An arrow sign.
CT scan. Good, good. On the right track. Yeah. So what we have is, we have the aorta, and one of them is a false lumen, and one of them is the true lumen. So the one that's a little bit brighter is going to be the true lumen. You can see that dissection like right down it, so it's pretty evident on this image. And then we have, our other views here that also show the prominence or dissection of dissected wall kind of moving down there. Other imaging modalities, so like a transesophageal echo, which is where we're gonna, you place our echo down the throat or in the esophagus. This requires like sedation and general anesthesia. So this is something we don't normally perform in the emergency department. Now, if you have, and this is gonna be somebody admitted they have a non-diagnostic CT, but we still suspect it, they may get a TED, but not very common for, in the emergency department. And then it has, a higher false positive and negative rate. MRAs are great. MRIs are great for everything, they just take longer and they're not a tool we use in the ED. So, if you're thinking about board questions, really, the only time we're getting an MRI in the ED is if we want to rule out cauda-equina syndrome. So that's a good rule of thumb for your boards if it's in the emergency department. Here's going to be that transesophageal echo, showing that intimal flap on there and that true lumen and false lumen. And then here's another ultrasound image of that as well. This one is we have color flow on it or Doppler flow evaluating the vasculature. So if it's coming towards you, it's red. If it's moving away from your probe, it's blue, which we'll cover in block 5. All right, so what do we do for treatment of these patients? So one of our largest concerns is going to be reducing that blood pressure and that heart rate. So typically we want them under 120, and we use a beta blocker or beta blocker therapy for these patients. So what is a fast beta blocker that we use in the ER? Esmolol. So esmolol's fast on, fast off. Very short half-life, which is why we like it. Because if we're overcorrecting, or sometimes when I suspect it in a patient, I may start this first, but you guys don't even know that. We may start this first if we're really concerned for it before we get our imaging, and then it's easy to turn it off afterwards if it ends up coming back normal. But the goal, get that blood pressure under 120. We want to use like an inotropic agent, so the little term we like to say, control the rate, then vasodilate. So we use that beta blocker to reduce that shear force on the wall. And then we want to look at vasodilating them with some sort of nitrate. So nitroprusside is one we can use after we give them that negative inotropic agent. We want their heart rate usually below 60 is what our goal is for these patients. We can also use, let's say they have an allergy, we can use other medications like nicardipine is another one we can use. Or if there's a contraindication for a nitroprusside or nitrate. Labetalol works as well. Theoretically it could be better, but in practice it doesn't work. It's usually inadequate to control the BP. But because it's like a non-selective beta blocker, it theoretically can control the rate and the hypertension, but doesn't work as well in practice. If the beta blocker is contraindicated, we use a calcium channel blocker like Diltiazem and EMED. So if they have an allergy to beta blockers, we'll use Dil. And what do we do? These patients are going to be admitted, especially if it's an acute aortic dissection. So they need a vascular surgeon, and then especially if it's the ascending aorta, they're going to go immediately to surgery, and they'll do some sort of endovascular repair on these patients. If it's the descending aorta or a type B, then they might be managed medically, but that's going to be up to your consultants. We're still going to call the cardiothoracic surgeon for those as well, and they may decide to just medically manage them with medications. All right, so they're going to place some sort of stent in there to help occlude that dissection that we have in that medial layer, so we can hopefully correct it back to the correct flow for the aorta. There are endovascular therapies for it. They don't work as well. They have a lot higher mortality rate. So it's not something we use as commonly. And that's going to be up to the surgeon. It's not up to us in the emergency department. But the goal is to just stabilize that true lumen of, we want to prevent any blood from going into that dissection. And then eventually that thrombus in there will resorb. So all of them are either admitted to surgery or they're going to the ICU for management. And the surgeon will decide what they're gonna do, whether they need to do surgery right now for, that's the bottom line. All these patients, yep, commit to surgery. So pregnancy, I kind of mentioned at the beginning, they have a higher risk for this during pregnancy, so it is something we need to consider. It is still very rare, but if it is, the secondary pregnancy is usually in the later trimester or in the postpartum period, so it is something we want to consider in those pregnant patients. If they're, especially if they're presenting with that typical ripping, tearing chest pain, or if they have any sort of connective tissue disorder, which is, they already know they do, they're hopefully managed appropriately and counseled on these risks associated with it. But this one, if they're going to surgery, we consult OB too, especially if there's a pregnancy or a viable fetus in there, they might look at delivering the fetus first before they operate. So, you know, we have, most of the mortality is from some sort of complication from it. If it's near that aortic root, then we run the risk of tamponade. If it can unseat that aortic valve, which can, you know, complicate this treatment for the patients. You can have a free rupture. Then you can have ischemia as well to any organ really if you're cutting off that blood supply to it. All right, let's move into hypertensive emergency and urgency. So we don't call, technically there's not hypertensive urgency, there's just emergency. But we'll cover what falls, we really just call it hypertension in urgency now. It used to be called emergency and urgency. And, you know, they've been saying this for years. Like I know when I went to fellowship in 2020, they were like, it's no longer a thing, but it's still a diagnosis in all of your medical charts, and it has an ICD-10 code, but whatever. Technically, it's not a thing. But what is hypertensive emergency? So for you guys, especially on your rotations or when you're in the ER and the precept, you're gonna come to me and be like, he has significant, it's crazy high, like 150 over, you know, 90 something, which is not very high in the emergency department. So there's no blood pressure that's really associated with it. Typically we say over 180, we need to think about a hypertensive emergency. Typically it's over 200 when I diagnose these. But the key to diagnosis is they have to have end organ damage. So whether that's in the brain, whether that's, you know, in the heart, lungs, kidneys. So these patients with this elevated blood pressure, we need to get an EKG, labs, troponin, check their kidney function, usually get a CT scan of the brain on these patients to assess for end organ damage. And then we don't love to acutely manage blood pressure in the ER unless it's going to affect our management, like for stroke or anything like that. And why do we think that is? Have we got an idea? Yeah.
You don't know what their normal is?
Yeah, so if their baseline was, a lot of these patients have lived with a 200 for years. And so any time we decrease that blood pressure quickly, we run the risk of like not perfusing areas of the brain because they're used to having those kind of dilated vessels in there, and really if we lower it too quickly, they'll then start to have stroke-like symptoms. So we hate to manage it in the emergency department unless there's end organ function, like end organ damage or dysfunction. So if we have to, we do very small increments. So like, you know, they say 20 to 30% over the next hour. Really, we're just trying to get them below that 185 mark in these patients. Is the general rule of thumb. There's no like hard set measure, but 20 to 30% is what we are concerned for unless it's a dissection. There are different medications we can use for it, especially if it's associated with some sort of end organ damage like acute coronary syndrome. We can use nitroglycerin to bring that down relatively quickly. Nicardipine is a great one, especially if we're concerned for that end organ damage being somewhere in the brain. Once again, esmolol is what most of us like to use because it's fast on, fast off. We can titrate it to an appropriate blood pressure and we can turn it off if we overshoot. There's just a recent study, it was regarding strokes. And if we, like the goal, if you guys remember from block 1, if they have a stroke, we want to get that blood pressure below 185. So the study was like how quick, because always the debate in the ER is like how quickly should we lower this blood pressure? And the study found actually when we lowered it within the first 2 hours down to a normal limit, like they had a significant increased mortality outcome. So it was kind of, maybe not what most people expected from that. So we titrate it down very slowly if we're managing that acute blood pressure. So what did we used to call urgency? It's very common in the emergency department. So if patients present because their blood pressure is really high, they checked it at home or they were at HEB or Walmart or something, and they present with an elevated blood pressure. Our goal is just to assess them for any evidence that end organ damage. So if they're asymptomatic, that's usually more reassuring. We may send them home with a blood pressure over 180 and not manage it, especially if they're on some sort of antihypertensive already. But for these patients, we take a good history and physical exam. And if they're asymptomatic, the current ACEP guidelines, which is the American College of Emergency Physicians, they actually recommend we don't do anything for these patients, not even get an EKG on them. What you'll find most of the time, if it's over 180, we'll get an EKG. And then if they're symptomatic, depending on our physical exam, they might not have presented with symptoms. If we find something on physical exam, we may do lab work or a CT scan on these patients. But we don't acutely lower the blood pressure. We may or may not send them home with a medication for blood pressure, but that's going to be provider dependent. Really, we don't do anything for hypertensive urgency as long as we don't have any end organ damage. And if we did, then it'd be an emergency. All right, so you got a 40-year-old, past medical history, bicuspid aortic valve, presents ED, sudden onset, severe tearing, chest pain, radiating the back. He's got a pulse deficit. We already got some history on there, so he has a past medical history of bicuspid aortic valve, which increases the risk for dissection. We have that physical exam finding on there of our pulse deficit. What are we going to do for diagnostic testing for this patient?
CTA.
Yeah, CT angio, right? What about our treatment? Yep, we want to beta block it first, control the rate, then we want to vasodilate so we can give some sort of nitrate like nitroprusside. Good. What else do I get? I think that's all right. What questions y'all got?
All of them.
Nothing? I'll hang around in case anybody has anything. But if not, have a good day.